Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Med Talks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra, Season 3. Doctors, as monsoon season has arrived in India in last 1 month back, and the whole monsoon that has taken India into its grasp, and we wanted to raise awareness about a serious medical condition named tropical fever. So we started a 6 lecture series especially for managing tropical fever. We have already covered one lecture last week that topic was acute topical fever, and our today's topic is nursing and home care in fever. Now, today's session is brought to you by your zero calorie hydration partner, Enerza Zero. Now, before moving forward, I would like to announce the last week quiz winners: Dr. Bhimarao Bange from Kolhapur, Dr. Vinay Desai from Thane, Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Gangadhar Rath from Bhubaneswar, Dr. Sanjay Shiroha from Surat, Dr. Balawan Nagde from Hubli, Dr. Farid Khimani from Mumbai, Dr. Anand Purande from Mumbai, Dr. Ravi Bhatt from Sirsi, Dr. Sanjeev Puri from Hoshiarpur, Dr. Ramesh Hegde from Bangalore, Dr. Bharat Praveen Mitakota from Surat, Dr. Rajiv Handa from Delhi, Dr. Vinay Agarwal from Pune, Dr. Javed Ahmed from Mumbai, Dr. Pankaj Shugla from Baban, and Dr. Sumit Sharma from New Delhi. So thank you all the doctors to take part in our quiz. Now, before moving forward, I would like to welcome our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society, and Dr. Sunit Verma, MBBS MD General Medicine from Panchkula. So thank you all the doctors, and please.
Thank you, Ankur, for that warm welcome and good evening, everyone. This is the second episode of our series of tropical fevers. And last week we had a great kickstart with Dr. Sunit Verma. Sir is, of course, the expert of Garmi. So whether you are treating Garmi or whether you are causing Garmi in different ways, Dr. Sunit is the go-to person. And yes, last week was actually a record session for us because the question answer session went on till I think 80 minutes. 79 or 89 minutes, I'm not sure. That was a record for Diabetes Essentials. We'll continue with the process today. Last week, Dr. Sunit had spoken to us about tropical fevers, how to diagnose, how to treat. But there's a lot of treatment that is done at home, lots of issues that are related to home care. So that's what we'll speak about today. And for the questions, we'll have Dr. Sunit joining us for the answers as well. So our topic for today is, if you can see the slides, it's home care and nursing care in fever. Now, fever is an important indicator of the body's fight against infection or illness. So fever is good actually. It tells you that there is a problem. You begin taking care of yourself. It fights the infection, whether bacterial, viral, fungal, protozoal. It's an indicator of the response to a pathogen. And fever is associated with production of white blood cells. So all this means that fever is good. Fever is an adaptive mechanism. But sometimes fever can become maladaptive. So too much of anything is bad. And there are times when fever is maladaptive. When you are managing fever, there are 2 points. The first is you are managing the fever, the discomfort, the symptoms, so that the person can get back to well-being and the person can get back to work. But the second thing is that you have to manage the etiology, the cause as well. Sometimes by managing fever alone, you tend to forget the cause. So do keep both things in mind. If your patient has low-grade fever, that is defined as a fever or a temperature less than 101 degrees Fahrenheit. So a temperature less than 1 degrees Fahrenheit, that's low-grade fever. This usually cures itself within a few days. It's self-limiting, and it can be associated with flu, common cold. If the patient has a temperature between 101 and 102.2 degrees Fahrenheit, that's called moderate fever. It can be linked to more serious illness, which can be a pneumonia, a skin and soft tissue infection. It can be a urinary tract infection as well. Moderate fever or high fever can be associated with chills and rigors. Chills means it's a symptom. The person feels cold. Rigor is a sign. The doctor or a third person observes that the person is shaking because of extreme feeling of cold. So chills is a symptom, rigors is a sign. And if you have chills and rigors or either of them, usually it is a tubular tract infection that is causing the problem. It can be a biliary tract infection like cholecystitis, cholangitis. It can be a urinary tract infection. It can be a gastrointestinal infection as well. That's a tubular structure. And of course, it can be the ubiquitous malaria. High fever is defined as a body temperature more than 102.2 degrees Fahrenheit. And this can be associated with life threatening diseases or with the quality of life threatening, organ threatening diseases. It is important to manage high fever because the higher the temperature, the more the temperature of the delicate organs of the body, like the brain. So the brain can go into coagulation actually. Once I remember having chicken pox around 10 years ago, and the entire time I used to think that first I thought for the first 3 days I'm not going to survive. Then I thought I will survive, but something has happened to my brain. It's necrosed. Coagulation necrosis has occurred. I'll never be able to work again. But then things became okay. But in such a situation, it's very important to manage the temperature immediately, the fever immediately. The high grade fever can also be a sign that things are worsening. It can sometimes be iatrogenic as well. And if suddenly your patient moves to high grade fever, it means something is wrong. You need to do a clinical analysis again, a clinical workup. You also need to investigate once more. And another term called hyperpyrexia. This is defined as a temperature more than 160 degrees Fahrenheit. This is a medical emergency. Actually, brain damage can occur, seizures can occur. The patient can go into multi-organ failure, and it's an emergency. You have to act immediately. Now, these definitions and classifications are based on the degree of fever, the temperature. The cutoffs are 101 degrees, 102.2 degrees, and 106 degrees for low grade, moderate grade, high grade, and hyperpyrexia fever. Another way of assessing fever is to see the temporal profile. So continuous fever it's the same temperature, minimal fluctuation. Temperature remains high for a long period of time. That's seen with bacterial infections. Remittent fever, a lot of fluctuation, but you never touch baseline. That is viral infections. Intermittent fever, fever comes and goes, and you have normal temperature in between. Then again, you are back to febrile times. That is a protozoal infection like malaria. And Pell-Epstein fever is quite rare. It can occur in Hodgkin's lymphoma, in other hematologic malignancies. There are periodic spikes. They can last for several days or weeks, and then in between, you have normal temperature. So, the first thing in nursing actually is to recognize the type of fever. And you can recognize that only if you check the temperature. So, temperature charting is very important. As a doctor, when you are speaking with patients, tell them that temperature charting is of utmost importance. And you have to write it down with the time, with the date. Don't just commit it to your memory. As a person with fever or as a caregiver of a person with fever, do remember that is the single best thing you can do for your loved one. Check, monitor, write down the temperature, share it with your doctor so that the patterns can be seen. Vital signs must be checked. If the pulse increases suddenly, if the pulse becomes thready, if the BP falls, there may be a need to take the patient to hospital. If the patient's level of awareness, orientation, cognitive function falls, again, you may need hospitalization. Look for symptoms of dehydration. Is the person drinking enough fluid? What is the color of the urine? Is the urine output adequate? Are the axillae dry or not? That's also important. If your patient is dehydrated and is not able to take adequate fluids orally, then again, maybe admission is required. And of course, signs of infection. Local infection may be an earache, ear discharge, eye discharge, cough, hemoptysis, any skin infection. All these are things that you look for so that you can find the focus of infection. What are the interventions we can do at home when we are managing patients? First of all, adequate hydration. Encourage the patient to drink as many fluids as possible. It's not just water. The patient is losing fluid through sweat. The patient is also losing electrolytes through sweat. So give a an energy drink which has got fluids, which has also got electrolytes, and which has calories. So adequate hydration with micronutrient balance, with electrolyte balance. The second thing is cooling measures, like tepid sponge baths. We spoke about this last week, and we'll speak about it again in the question answer session. So you keep the patient cool. If the patient is able to tolerate fans, fine. Tepid sponge baths. How to give the sponge bath? Use the maximum surface area of the skin that is available. If you limit yourself just to the forehead, it's just this much of a surface area, and there's not much help that you're going to give to the patient. So use the abdomen, the torso, the upper limbs, the lower limbs, and apply maybe towels or linen that has been dipped in normal tap water, and then see what happens. Encourage evaporation from large surface areas. Like we said, it is important to monitor the patient's temperature. Don't forget to do that. And in case temperature is high, your doctor will tell you the threshold. You can prescribe a drug like acetaminophen or paracetamol. This will help the patient feel comfortable. At the same time, limit physical activity, limit unnecessary physical activity. The patient says, I run a marathon every day. That's fine, but let's take an off. It's good to have an off every now and then. When you become better, you can run 2 marathons in one day. We don't stop you from doing that. If there is a bacterial infection, then use antibiotics. At times, in sick patients, your doctor may prescribe an antibiotic to prevent superadded infection. Sometimes probiotics, prebiotics will also be prescribed. So the advantage of pre and probiotics is that you are able to improve the gut microbiome. It's called microbial modulation, and you are able to fight gastrointestinal disease or infection in a faster, more effective manner. While helping the person with fever, do you remember that your responsibility is also to stop the chain of transmission? So if it is an infectious disease, maybe which is being spread by droplet, by cough, then maintain social distance. If it's being spread through touch, then hand hygiene is important. So be aware of this and keep yourself educated. Make sure that the patient is sticks to his or her own bed linen, towels, plates, so that the infection is not spread to other people in the family. Is there an outcome? Of course, each patient is different, but within 72 hours, usually we should have brought the temperature down to less than 38 degrees. Let's remember this mnemonic for fever nursing. Fever D. F for fluids, hydration. E for elevate, elevate the head of the bed to promote comfort. It helps reduce headache also. V for vital signs, especially temperature to be monitored. E for environment, maintain a comfortable and cool environment. R is rest, encourage the patient to rest and relax, mental as well as physical relaxation. Rest and relaxation will also mean staying away from the phone, from WhatsApp. And D is for drugs, use paracetamol or any other drug as advised by the physician. Now we come to two questions today. Our first question is, fever is a sign of. Is it a sign of failure of the body? Is it a fighting mechanism of the body? Is it just a sign of fulminant infection, or is it all of the above? So our first question, fever is a sign of the body having failed, the body fighting, the body being faced with fulminant infection, or all of the above. And our second question, now we had E for environment, and we had E for elevation of the head. What other E's come to your mind when you're managing fever at home? So our question is, good hydration during fever should focus on providing fluids, calories, electrolytes, or all of the above. What is it that we want to do when we give adequate hydration to our patient? With this, let's move on to the questions, and we welcome Dr. Suneet back to stage. Dr. Suneet, warm welcome.
Thank you, sir. Thank you so much, and very lucid and very uh, expressive and talk as usual by you. And in short, you have explained very nicely how to monitor fever and how do we take care of fever, how our nursing staff is supposed to act, how things can be managed at home. So that is very important when we say that a patient is at home. Not all patients of fever can be admitted. Patients of fever can be managed at home. As you rightly pointed out, if patient is having hyperpyrexia, his temperature is going beyond 106, there is no point of management at home. If somebody is not able to shift patient to hospital immediately, at least to sponging, cold sponging. As we discussed, what is cold sponging doesn't mean ice cold. It's a normal temperature, normal room temperature water, or maybe lukewarm water. And by evaporation technique, we can decrease the temperature immediately. And that is an awesome way of doing it. Second is like, again, if patient is having, we all know that this is a viral fever season going on, maybe some particular season, and we know this particular illness is going on in the particular community, and that needs simple hydration, paracetamol, and like dietary care. So these kind of things can be very well managed at home. And this home management, how to do, you have explained very nicely and brief in a brief and very nice manner. So,
Thanks.
I think
We have many questions, Dr. Sunil, today, and we welcome everyone who has logged in. Mr. Sharma is a nursing faculty at SGPGI Lucknow, and he highlights the need for good nursing care. Of course, medical care is important, but medical care alone does not work. It is nursing care which is more important. So I, for example, remember my tryst with the chickenpox, which was actually very bad. Adult chickenpox is not a good thing to have, and it is the nursing care which got me through at home. So people continuing to speak with you, make sure that you are lucid to get you out of the system. So nursing care is really, really important. A question from Dr. Shazana Haider Ali. Sir, what proton pump inhibitor can we give to persons with dengue fever?
any proton pump inhibitor can be given. As we know, uh, patients with dengue fever, they have a lots of nausea, vomiting associated with it, and they have epigastric pain, and they are not able to eat. So, to give them a symptomatic relief, to reduce the chances of nausea, vomiting, any PPI can be used, and proton pump inhibitors are effective, useful, and safe. To can be used in dengue fever.
So, Dr. Shazana, anyone that you feel like and you can use it, it will help in prophylaxis of gastritis also, drug-induced gastritis or GERD. In some patients, you may wish to use a pre-probiotic as well if proton pump inhibitor usage is going to be prolonged. Another question from Dr. Heather Ali is, sir, what about COX-2 inhibitors? Can we use these in dengue fever?
So, any beta COX-2 inhibitor, be it routine COX-1, COX-1 inhibitors, routine painkillers, they should be avoided in dengue fever. All of them have a potential to cause platelet dysfunction. They should be avoided as far as possible. And usually, in our practice, what we do, we don't use them. And if I'm sitting at a tertiary care center, I'm able to avoid it. So, and also looking at a patients at a primary, like a primary care physician also in OPDs. So, this should be avoided, and one should not use it.
Dr. Suresh Shukla has a query. What is the role of CRP in fever diagnosis, in fever monitoring?
Very nice question, sir. CRP is a marker of inflammation. It's a very important marker. If patient is having some autoimmune disorder going on, some other illness going on already prior to this fever episode, so there is some limited usefulness of CRP in that particular patient. Otherwise, CRP is a very good marker of inflammation, ongoing infection. CRP has a like short half life, so the value can vary from day to day. If patient is having increasing CRP from day 1 to day 2, day 3, probably the infection is actually increasing. TLC or other markers may not change in the span of 2 to 3 days. So that's how we can monitor by using CRP. It should be quantitative CRP to actually nothing, no inference can be drawn from a CRP positive or negative for following up with the patient. So this is definitely helpful, sir. When we are like a patient is having TLC count of maybe in some infection, maybe 16,000, 17,000 is a higher side. CRP earlier was maybe 120, 130, 140, 200. Now CRP is decreased to 80, 90. PLC is not decreasing. Then also we are on right track. You can be assured that here we are definitely on right track. So this way we can monitor our own treatment, and definitely it's a very helpful.
Right. Thank you from Dr. Shilendra Tiwari and Chirag Kaushik. So, thanking you for your lucid answers. What is the commonest mistake that you see, sir, in your patients in terms of nursing? So, when let's say you've done the best possible medical management, you did all the investigations, you prescribed the right treatment. Is there something wrong that we go in terms of nursing at home?
Misconception about use of paracetamol. Paracetamol uses is like, even I'm sitting at a reasonably good educated area. Tri-City is one of the most like educated area we can see in India, not a rural area. Even there is a confusion regarding 500 milligram of PCM versus 650 milligram of PCM. When we say take 650, so this is just too much of a dose. 650 looks like a too much of a dose, but for an adult, 650 milligram paracetamol is the dose to decrease temperature. 500 milligram is not going to work. Then there is a confusion at home. We have taken paracetamol 10 minutes before and fever is not going down. Fever is going to take at least 2 hours after taking 1.5 to 2 hours after taking paracetamol to go down. So please don't panic. Don't take another medicine immediately, maybe 30 minutes after taking first medicine. How much dose of paracetamol can be taken at home? Very simple. Now it's a 4 gram, but to be on safer side, we usually say 4 times in a day. 650 milligram of paracetamol can be taken very safely. Even can be taken up maybe fourth or fifth early. Okay. Another very common confusion in the nursing care of fever is, डॉक्टर साहब बुखार तो उतर ही नहीं रहा, अब क्या करूं? मैंने जब पैरासीटामोल दी थी उस समय तो 102 था, अभी तो 104 हो गई, ये बुखार बढ़ा रही है, घटा नहीं रही. फीवर नहीं बढ़ाती है. आपसे बिल्कुल ठीक कहना है आपका, आपका ऑब्जर्वेशन ठीक है, पर इंटरप्रिटेशन खराब है, गलत है वो थोड़ा. वो किस ढंग से गलत है? पैरासीटामोल लेने से फीवर कंट्रोल नहीं आया, उसने बढ़ा नहीं दिया. बट दैट डजंट मीन कि आप 2 घंटे में पैरासीटामोल की दोबारा डोज ले. Minimum gap between 2 tablets of paracetamol 650 is at least 4 hours. At least 4 hours. Ideally, we say 5 hours or 6 hours. At least 4 hours. What if the temperature is increasing? तो घर पे क्या करें? Then comes the role of cold sponsor. That is a very nice thing, very easily doable, very cheap, but it requires some support from family. So this can be done. These are two very common things which I face frequently. These are frequent questions from my patients: paracetamol underdosing and frequency of paracetamol to be given. What if fever does not go down?
Another question that has come up is role of mefenamic acid. Supposing we have given maximal doses of paracetamol, can we give mefenamic acid to bring the fever down?
No, sir. During this particular time, specifically, I tell you, sir, 15th of July to 15th of November, when we see patients of dengue and other illnesses having thrombocytopenia, I usually tell my patient, unless until we are very sure this illness is not affecting platelets, we don't give any type of NSAIDs. So, mefenamic acid is an excellent tablet to decrease temperature. An excellent tablet, no confusion. But should be avoided unless until we are very sure that we are not dealing with thrombocytopenic conditions because of dengue fever.
Another question is there is a tendency amongst many patients to keep on taking acetaminophen or paracetamol, even if the temperature is not rising. So, what should we suggest? Maybe we can structure the question as follows: the first 2 days of fever, when you know that things are going to worsen, and maybe after 4 or 5 days of fever, when you are moving towards convalescence, should we advise an SOS or PRN approach to paracetamol use, or should it be regular round the clock?
What I tell my patients is always an SOS approach, but I guide them very specifically that you check your temperature. If somebody is having limitations, is not able to check temperature or doesn't want to check temperature or some sport is not there, then we say in the first 2 3 days take paracetamol 6 hourly, and afterwards you need to take paracetamol only when you feel fever. Actually, temperature more than 100 degrees, specifically not 100.4. Patient keeps on forgetting these things, so I tell them temperature more than 100 degrees. Then only take paracetamol. Paracetamol is a good medication for headache as well. It's also a very good medicine for myalgias, non-specific myalgias associated with fever. So paracetamol can be used in an afebrile patient if they are having lots of myalgia. This will help them.
One question is can paracetamol make me feel sleepy?
It's rather dehydration and lack of or some dyslipidemia, which is making you and increase in chemokines or cytokine levels because of fever that is making you drowsy rather than paracetamol.
Dr. Nitin has a question, Dr. Nitin Jadhav, and a very pertinent question. Misconception about taking bath. So, somebody has fever, viral fever. Can the person take a bath or not? Can the person shave or not?
Two different questions now, sir. Shave and bath. Shave involves something which can produce cuts. If patient is having severe thrombocytopenia, severe thrombocytopenia from medical point of view, not from a bookish point of view, from medical point of view, is platelet count less than 20,000. We say no, please don't do it. If patient is having a decreasing trend of platelet count, confirmed case of dengue, platelet count are going below 50,000, we say please refrain from shaving. Platelet counts are increasing, gone beyond 50,000, one can shave easily. Bathing is never contraindicated, was never contraindicated, can be. Only issue with bathing is if patient is having postal symptoms because of postal hypotension, dehydration, or maybe extreme weakness, then we say be cautious. Please don't bolt the door of your washroom. Keep someone handy at outside if you need some help. But otherwise, there is no contraindication of bath. Bathing is going to make things better, not worse. Important is temperature of water you are using. हम अक्सर कहते हैं कोसा पानी से नहाओ, बिल्कुल चिल्ड पानी से मत नहाओ.
So, in this season, perhaps tap water would be fine across almost all of
Tap
India.
water is good.
Dr. Manisha Sharma agrees with you. Your dosage and style of using paracetamol, 650 milligram, usually on a PRN or SOS basis. Mr. Sharma asked about fever profile. Sharma ji, sir, I would request that we'll request Faraz. Faraz is with us backstage, and Ankur is there. They'll put up a link to the previous week's show that lasted for about 80 minutes. So we'll have that. And over the next 4 weeks, we'll have discussions on different aspects of fever. And we'll be covering tropical fevers in 6 weeks. So if Faraz or Ankur could put up the link to previous week's discussion, which was handled very well by Dr. Suneet Verma, that would be good information. And we'll continue with the discussion of the next 4 weeks. Dr. Suneet, it's been great having you with us. Thank you for joining us last week and this week as well. Our
Pleasure is mine,
aim is
sir.
to ensure that there is rational use of tropical fevers. We should not be afraid of the fevers. At the same time, we should not ignore them, and we should be able to treat them in a rational manner.
जी sir.
I'd like to thank everyone for having logged in. This is our journey of diabetes essentials. But you see, people with diabetes, people without diabetes, anybody can develop fever. And this was the fever season. That is why Mr. Anand Basu had this idea of discussing tropical fevers. We'll be doing different aspects of fevers over the next 4 weeks as well. And Dr. Suneet, once again, thank you so much.
Thank you, sir. Thank you so much.
There was one question pending from last week, Dr. Sunil. Would you want to keep that
Leptospira.
pending?
Leptospira. How do we diagnose leptospira?
Yeah.
Leptospira, regarding the antigen test. Yes, that antigen test is available. It's a costly test. It's a DNA-based, PCR-based test. So that is costly. Definitely, it can detect leptospira in urine sample or a blood sample or CSF sample in the first week of illness. Otherwise, again, the most commonly used thing is IgM antibodies in the second week.
So you can do a test in the first week on CSF, urine, or blood, but it is a bit expensive. And otherwise, routinely, what we
Yes,
use
yes.
is in the second week, IgM antibodies.
IgM antibodies,
IgM.
especially for
Thank you.
leptospira.
Right.
Limitation of IgM antibodies is they are sometimes do not develop within the 7 days. So if somebody is ordering test on day 8, patient may not have. So book says 7 to 10 days after infection. So one may, if clinically suspected, strongly suspected, and first test is negative, one can repeat after 3 days.
Sir, if you could take one more question, please. This question is from Dr. Manisha Sharma. She shares a clinical presentation. Adult patient with temperature of 104 degrees Fahrenheit. WBCs, platelets, RBCs, all three are low. So what does that indicate? And secondly, the patient has high ferritin. What does that indicate separately?
Uh, Huge number of differential diagnosis, infectious, non-infectious. Let's limit our discussion to infectious diagnosis. So infectious can be viral. Among viral, during this season, the most common is please rule out dengue. Even malaria can lead to same problem, falciparum malaria, bone marrow depression, all three lineages goes down. Then is scrub typhus, leptospirosis. They all can have these kind of findings. In leptospirosis, usually there is a leukocytosis. Lineage also well known. Another is any typhoid fever, very common typhoid fever. Typhoid fever can lead to this same presentation. So this presentation is pretty common during this season. All lineage goes down. Mild anemia. Anemia may or may not be related to current episode of fever. Maybe he or she is having underlying anemia for quite some time. Now we are just looking at it. Mild leukopenia and mild thrombocytopenia is pretty common in almost every illness coming during this season.
Basically, what it indicates is, Dr. Manisha, there is a bone marrow suppression. So there is a systemic effect of the high temperature. And secondly, the high ferritin, it's an acute phase reactant. So something has happened suddenly to the body. So that's what it's telling you. And then we have to find the cause now for that sudden fever.
Acute ferritin, sir, I would like to add acute ferritin one should not use so often. It's
One should
not
not
going to
use
help.
ferritin as an acute phase reactant. That is what you're saying.
One should not use this in diagnosing some cause of fever and routinely. Ferritin again become a very fancy word during COVID time. We just need to understand there was nothing at that time. Our understanding of COVID was very less, still is very less. It, so whatsoever they could find was projected. Ferritin is not going to add anything to the cause of fever. Why fever is there? It's like raised ESR. डॉक्टर साहब ESR बढ़ा कारण बताओ. That becomes actually a difficult question. CRP बढ़ा हुआ कारण बताओ. So CRP is a it's an inflammatory marker. It's a non-specific marker. Same as ferritin. It's acute phase reactant. You know, platelet is also acute phase reactant. In many cases, there is a thrombocytosis, an infection. Even in anemia, there is a definite thrombocytosis, especially in IDS. But we need to check this platelet count for some other reason. We are checking for thrombocytopenia at this point of time. Is there something serious going on? If platelet count goes below maybe 20, 30,000, we need to have eye on it. That's why we are checking. Another very important thing I would like to point out, sir, is a confusion regarding WBC count in dengue. Doctor, my TLC is 2300. Give me something to improve it. By this means my infection is actually increasing. I may die. And these are actual statements, sir, but we hear from our patients and their attendants. There is nothing to be done. They just need something. We should be very clear in our mind that there is nothing we should do to prevent this WBC falling in a dengue patient or to increase this WBC. This will increase, this will improve of its own. Please stop looking at it. What we need to look at is platelet PCV or hematocrit. That's enough.
Hematocrit and not only the specific platelet count, maybe the temporal profile or the trajectory of the platelet count, whether it's going up or coming down. Dr. Mukesh has a question. Sir, supposing doxycycline is contraindicated in scrub typhus, may I use azithromycin? And how effective is it?
So scrub typhus can be dealt with ceftriaxone and doxycycline. Azithromycin is effective, but ceftriaxone with maybe if doxycycline cannot be given, ceftriaxone is good. Scrub typhus is a sensitive kind of organism that the causative agent is, and can be well dealt with most of the antibiotics. So ceftriaxone is effective, sir.
Thank you. And another thank you from Kunal Kaushal, Dr. Kunal Kaushal. A very nice talk, and you've explained all these things to us in such a simple manner.
Thank you, sir.
I would like to thank you once again, Dr. Sunit, for being with us, for
Thank
helping
you.
us in this endeavor to spread awareness about fever and its management. And I'd also like to thank Mr. Basu, Anang Basu, whose idea it was. So over to Mr. Basu. He is there with us today.
Thank
Thank
you,
you,
sir.
sir. I think with this we are warming up actually, sir, because I can see questions coming up for the next seasons of sessions of the Diabetic Essential where we are taking tropical fevers because today's questions were hovering around tests as well as usage and the usage of antibiotics, which we will be definitely covering under the guidance of Dr. Sanjay Kalra and Dr. Sunit sir, because with these two sessions we have understood that there are questions coming up on those lines, and exactly the Kalra sir has lined up those sessions in coming 4 sessions. Sir. With this, I sincerely thanks Sunit sir to be with us for taking up the last week's not taken questions also, as well as this week's question also. And sincerely thanks to Dr. Sanjay Kalra because he has taken such a wonderful session on nursing and home care on fever, sir, which has clearly given guidelines to all the doctors what are the guidelines to be taken. With this, I sincerely thank both the doctors and saying good night and Jai Hind.
Thank
Jai
you,
Hind.
sir. Jai Hind.